All right. All right, Scott. I know like I have you like multiple times. So, and like Adam mentioned, like you're probably one of the smartest guys out there. So I'm just gonna straight ask you like a bunch of questions. And the first one would be probably a little bit a hot topic because obviously all the pro sports are doing this biomechanics lab right now. And I've been talking to different people about like uh talking to tendon expert, talking to biomechanists about this biomechanics lab. What do you think we can get out of this biomechanics lab thing?
Yeah, I mean, I have a bit of a saying, right? The biomechanics is so 90s. Um, I don't mean that wholeheartedly, and it's a little bit flippant, for me to say it just like that. But I think that one of the things is we've really been digging into biomechanics in a lot of different injuries, particularly ACL injuries, over many, many years now. And we've certainly identified, various tendencies and deficiencies or anomalies of movement patterns, as we might call it. But I don't think we've gotten any closer to solving the problem, and certainly the injury rates would suggest that we haven't gotten any closer to solving the problem. So, what I mean when I say, biomechanics is so 90s is that there's got to be a whole lot more to the story. And to answer the question, what can we get out of this? We get a whole lot of data, and we get a whole lot of data in an athlete population that previously has been difficult to study in a controlled manner. So, we're using the same system across the NBA. It's getting analyzed basically the same way. The tests are being done the same, and so we have a homogeneous sample of elite athletes. We previously were making inferences about elite athletes from adolescent female soccer players or, various other groups, and then trying to infer, well, this is how you tear your ACL. And if you look at Adam and my paper and ACL injuries in the NBA, very few of them involved the manner in which you would see from the biomechanics studies, i.e., the classic kind of valgus adduction internal rotation. There were very, solid deceleration injuries or reaching outside of your base. They weren't from landing from a height, and yet, of course, all of the studies we looked at were, depth jumps and things like that to make these inferences. So, in basketball, knee valgus and adduction is almost part of some of the movement patterns that players use. Just look at Kevin Durant, if you want to see that. So, I think we're going to have a lot of data in an athlete population that's elite. And it'll be interesting to see then, how that correlates to some of the other things we know. And Adam always talks about, the athlete, in the wild versus the athlete in the cage, or the tiger in the wild versus the tiger in the cage, and how we move is different. And when we give athletes a very prescriptive movement task to do, that's not necessarily what they're going to do in the natural environment. And they're responding to cognitive cues from the defense, and they're, also generating a certain movement pattern in order to create offense, or then they're absorbing a force from a player, in contact. All of these things are so many other variables. We haven't even gotten to the biology yet. So, you know, biomechanics really, stimulates a cellular process. It's, from a biological perspective, whether that's bone, whether that's tendon, whether that's muscle, whether it's fascia, whatever it is. And so, that's the another piece. We haven't talked about morphology. Obviously ACLs comes to mind. We think of shallow notches or posterior sloping tibias or, coxavere and hip angle and, all of those sorts of things that, we can't change. And so I think that it will give us more information that then needs to be correlated back to what the epidemiologic studies are telling us, to what the biology is telling us. It's unlikely that it's transferable across different populations. Soccer ACLs occur differently to basketball ACLs. That's been shown. That's Della Villa's work as well. And we compare Della Villa's work to our work and my experience in both sports. I absolutely agree with that. Um, and I think that uh, it's going to be more contextual, but it will give us data on an elite population previously unstudied in a controlled manner.
Nice. So, like you said, it's a control matter. And like Adam said, like playing sports is not in a control like situation. So, um, how how can we so is that why when it like when baseball use the whole biomechanics motion capture, it's much more helpful to them compared to us?
I mean, I, I'm not sure. I think there's a couple of pieces, obviously, for baseball where we're looking at also performance, where we're looking at injury prevention, and I am, as much as I consult with MLB teams, it's typically on tendon injuries and various other things, bone stress injuries. I am far from, the thrower's elbow expert in the field. There's many people who know a lot more about that and are far more qualified to talk on that topic. But I think that um, there's the performance piece of what you're getting out of it, and then there's of course the injury prevention piece in pitches in particular. Uh, One of the things that coming back to what we talked about is you're talking about, for the most part, a pre-planned movement pattern. You're throwing a baseball. So, that is somewhat, as much as it's happening in the premotor cortex and it's pre-programmed, and it's a very rapid movement. We think of Greg Myers' work and, some of the cortical changes that occur that he's now showing with his fMRI studies, and then combining that with functional movement tasks, right? Um, you know, it is still somewhat of a cognitive pre-planned movement that you can then make some adaptations, change your pronation angle, lift your elbow a little bit, or, work on scapular control and position, and then, improve the speed at which you can control that scapula. I think in an uncontrolled environment where you're making decisions based on the defense and you're reacting, to other cognitive cues, uh, I think it's a little bit different. And I think that's probably some of the reasons why it has been successful in baseball.
Nice, nice. All right, I'm gonna jump in the next topic, although it's kind of related, but um, I want to talk about tendon health. Obviously, like we kind of talked about it last year, and this year there's like a tendon conference just for like the reason. So, um, and this year I've been doing a lot of research about like tendon. And what I realized is there's like different theory about tendon structure and tendon health. So, I think there's research been saying like if it's a de degenerative tendon, you can't change the structure. But at the same time, there's also research saying like you can. What are your thoughts on this?
Yeah, so some of the earlier research, and we're talking about, Jill Cook's work coming out of Australia and her group at La Trobe. And, full disclosure to everybody listening, Jill is a close personal friend and mentor of mine, and somebody who I've spent many, many hours with talking about this topic and in and around. I brought her out here to the US. She's lectured and we've consulted on cases and players together. Um, but her earlier work and the model put out by her and Craig Purdom from, formerly from the Australian Institute of Sport, also a mentor and friend of mine, where they delineate the reactive tendon versus the degenerative tendon. There's no question that there's a difference. And I think, structure, if you look at other people's work, to your point, right, there's the BFR study that shows that you can increase the cross-sectional area of the tendon and increase collagen deposition by BFR work. But that only addresses kind of one element of the tendon, and that's just adding, some collagen to make it thicker. Obviously, the tendon will do that in somewhat of a disorganized way in response, to inappropriate loading or injury and what have you, micro tear, micro trauma, friction, intratendinous pressure, all of the above are all factors that we now know exist in tendon pathology. So, you know, just changing the structure of the tendon doesn't necessarily change the function of the tendon. You have to think about the intravesicular gliding and how those fascicles move on each other. You have to think about, the peritendon. You have to think, about the inflammatory response and what that does and its upregulation to these, precursors, tendon cells. Some have termed in the literature tendon stem cells. They're more like fibroblasts, precursor cells. And, we know that these kind of, tendon stem cells get upregulated in response to prostaglandin E2. And so there's these responses. And I think some people have then used that to say, see, we can regenerate these tendons because they are making more of these fibroblasts. The problem is that's also part of the pathology. Tendon cells in a healthy tendon are quite sparse. They're very elongated. They're communicating by these gap junctions with each other, as well as other chemical and chemotactic communications, but they're not densely populated. A pathologic tendon shows densely populated, short, more cuboidal cells, a lot of these tendon stem cells. And so now we're kind of in a little bit of a circular argument because we're kind of saying that the pathology is theoretically the cure for the tendon, like the tendon is curing itself, but that's also a pathologic state for the tendon to be in. So how do we get the tendon out of that state and then back into a healthy state? So I think it's a complex discussion, and I do think that we understand that yes, there can be some structural change in the tendon within reason. I don't think you can heal completely pathologic tendon. I think within reason you can make some structural changes to the tendon. And I think that that's what the literature really shows us. If you look at it as a whole, rather than just myopically taking a little bit from here to kind of suit your argument, which to be fair is kind of where a lot of these arguments come from, right? Is we want to support our argument for PRP or for this or for that intervention. And so we're going to take that, as Jill and Craig call them, the moldy oldies, the 60-something-year-old tendon that's got degenerative changes in it. They're really crappy tendons. You're probably not changing the structure in that tendon much, in terms of healing the tendon.
So if that's the case, like, because if you scan like high level athletes tendon, no matter it's like patellar tendon or Achilles tendon, a lot of them are probably like degenerative tendon, and it's from a pathological standpoint, it's probably not in the best place. So how should we deal with that?
Well, let's talk about our G League study. So, going to be published. It's under review now. We spoke about it at the NBA Combine 2 years running. Um, so we took, just for the listeners, 4 G League teams. We had about 40 players that started the study, but then we ended up, I think, with around 30 after players, got traded or moved into the NBA teams. And we tracked them over the course of a G League season. We scanned them with grayscale ultrasound, we scanned them with shear wave elastography, we did an MRI, and then we looked at their jumping profile, their strength on the force plate, their strength profiles in terms of knee extension, and various other tests. And ultimately, what we found from that is that 80% of those people that we tested had pathology. And only 2 of those players during the course of the season became symptomatic. So what we can infer is that pathology alone isn't the source of the symptoms. However, something that we're starting to see and something that was borne out in in those subjects, but in that study, is vastus lateralis. So vastus lateralis is really, really key as a performance muscle. And I think it's something that I've appreciated more and more and more and more. And we've spent far too many years rabbiting on about VMO and forgotten the fact that it's just part of a whole, system down there. But, we see that atrophy of the vastus lateralis. I have a soccer player, U.S. women's national team player right now with atrophy of the vastus lateralis and patellar tendinopathy. You'll see that sometimes with patellofemoral pain as well. But the two can go hand in hand. And then what you see is the jump performance drops off. And so we're able to identify, you know, athletes can maintain jump height. They can do very, very very well at maintaining jump height, even when they start to feel some symptoms or pre-feeling the symptoms. But the changes are already occurring. They use other strategies. They use other biomechanical strategies in order to maintain the output that they need to achieve a task. But you'll start to see changes in peak concentric force, peak concentric or concentric impulse. You'll see eccentric braking impulse changes. You'll see all of these other changes. And those types of things, as well as quad strength, was lower in the preseason testing in those that became symptomatic. And you could see the change. And then it got worse and worse and worse as they became symptomatic. But it was already showing signs, even though they started the season asymptomatic. And I think that's the biggest take home here is, how can we identify a tendon that's potentially going to head in that direction? A non-pathologic tendon is probably almost not going to go that way unless you're an adolescent, in which case the tendon could become pathologic. And one of the discussions I've been having with one of my co-researchers, Wimi Dewogi, who's with the NBA Research Committee, but also used to be the Wizards doc, is starting to look at this now across longitudinally across, adolescents, males and females, comparing peak height velocity, maturation, and tendon changes in athletic, males and females. But I think if you're not in an adolescent population where we know the pathology develops, by the time you get to the NBA, by the time you get to the pros, you've got that pathology. It's really now about, the other pieces of the puzzle that make it either, manageable or it starts to become symptomatic.
Hmm. And I want to continue this conversation with like I've been reading research, like I said, and talking to a different tendon expert, and there's two theory about like patellar tendon and Achilles tendon health is uh some would say like if you want your patellar tendon to be healthy, you need to do leg extension, right? And uh if you want your Achilles tendon to be healthy, you need to do calf raise. Well, there's another theory that talk about if it's patellar tendon, either your calf is weak or you lack ankle range of motion. And if there's Achilles tendon, if you have Achilles tendonitis, either your glute is weak or you have your quad is weak. Talk to me about this.
Sure. I mean, break it down. Let's talk about some of the earliest studies. Okay, there was a believe it was a volleyball study. I think it was a South African study. It was probably early 2000s, and they identified decreased ankle dorsiflexion range in those that went on to become symptomatic during the course of a volleyball season. Elite players. I don't remember the exact level. And so um, from there, we were like, oh, ankle dorsiflexion is probably a factor here in looking at that. Um, so there's probably some truth to that, but it's a piece of a very large system. The only way to actually isolate the quadriceps and get, kind of peak levels of strain, which is what's required to then get the biological response and to restore all of those, the elasticity of the tendon, the gliding of the tendon from the intervesicular matrix, like all of those things, is to isolate with a knee extension type exercise. When you do a leg press, you can use all sorts of other muscles. And I'll give you a great example of this, and I tell a lot of people this. So I was asked to consult on a WNBA player who had had a surgery, and effectively this player was um, unable to fully extend the knee, but was able to leg press 250 pounds on that side. And so, and when I say unable to fully extend the knee, it was quadriceps inhibition. And we were trying to figure out, was this neurologic? Was this just, post-surgical? Was it, various other things? And so I think that was a real eye-opening moment, where I was like, wow, you could, leg press this much, single leg, without having a quad that can actually fully extend your knee. And so I think, recognizing that is really important and understanding that that's how. Now, does that mean you don't do leg press with a patella tendon? Absolutely not. Does that mean you don't do, squats or complex movements with patella tendon? No. It means you need to understand again what you're dealing with. If you think that you've got a calcific lesion in the inferior pole of the patella and it's impinging on the tendon in ranges of knee flexion, then yeah, I wouldn't be going into 90 degrees on a leg press machine. That's pretty silly, and that's just going to aggravate it. Or I wouldn't be going into deep squats or deep split stance positions, at least not initially until you calm the tendon down. And so, but if you don't have that and you've got, and you want to supplement your global strengthening work and still bring in some quad work, like a high wide leg press position for the foot is great for vastus lateralis. I use it all the time. A single leg lateral box step down, great for VL. And so getting into those positions in some of those compound movements to get VL going and really, stimulate it is really important. And we just, talked before about the importance of VL. So I think that again, it's getting, this kind of reductionist mentality and where in this space of everybody wants a recipe, how do I just cure this tendon, tell me what exercises I need to do. But every tendon's slightly different. Every tendon's got these different nuances. Some of them have, some patellofemoral elements and fat pad elements. Some of them don't. So, there's all these other nuances, and you already brought up the ankle. If you go to the Achilles tendon, then, I think sometimes, when you talk about dorsiflexion, I wonder if we don't overemphasize dorsiflexion and if that hasn't even been a precursor to some Achilles tendon injuries in terms of ruptures, because we're looking at about 48 degrees of ankle dorsiflexion on a straight hind leg at the rupture point as per Adam in my study. Um, and you know, most basketball players that I've worked with are probably going to be in around about the 30-degree range. Our average, I think, for our soccer team was about 35 degrees. And we know from another study that was done that you gain about 5 more degrees after you play, just from kind of everything loosening up and warming up. That's if, in a standing dorsiflexion test. So now you're up around that kind of 35 to 40-degree range, depending on where you started. And, you know, do we really need to keep, banging into that? I've looked with positional sensors at, functional basketball tasks in the past when I was with the Sixers and found that players don't really functionally on the court access that often the full range of ankle dorsiflexion that they have. And so are we overemphasizing that and mobilizing talocrural joints and stretching posterior chains, too much? And is that even potentially a predisposing factor? Now, back to your question about calf raises, it's another way to load the tendon. I think you need to apply force to different aspects of the tendon. I think longitudinally, gastroc, single leg heel rise, isolate the chain and the Achilles tendon. I'm a big fan of taking out the toe flexors and assessing that. I think too many people are overuse the FHL. So getting that big toe off the edge of a step and having them heel rise, and oftentimes somebody can't even get off the ground. And especially post Achilles tendon rupture, when they're coming back, you'll find that a lot, and their strength measures are within the 20% asymmetry, and everyone's like, oh, they're great. And then you say, can you get off the ground without your toe flexor? And they can't. And then, of course, if you keep pushing them, then they start to get medial ankle pain. And everyone says, oh, it must be your tib post. Well, it's not your tib post, it's your FHL, because you're overusing that and your FDL as your plantar flexor strategy. So, you need to isolate the cuff muscle complex. You need to isolate the tendon because we are very, very good compensators as a species. And and you need to do that in different positions, bent knee, straight knee. Obviously, you also, I believe, need to do that at different speeds. Jill and I have looked at this with ultrasound, as have some people that Jill works with in Australia. And, we looked at the different recruitment strategies whereby at higher speeds, effectively, if you get too high a speed, you get very little contraction of the muscle and the tendons just kind of acting like a spring. Uh, you know, at high speeds, you get more gastroc and soleus is just kind of isometric. And then at lower speeds, you get kind of a little bit more soleus function in terms of the movement, and gastroc is just kind of more isometric. And so, when I'm rehabbing a cuff, I'm always looking at doing it, at different speeds, at that kind of, 1 hertz, 60 beats per minute, and then getting up to that 120, and maybe even higher. The other part of that is loading it through full range because we need to have strong control at the end of range. And so, um, you know, the step back position, that false step in basketball where these injuries occur. I work that in basketball players, but and also soccer players, football players, off a step down off a box and then a drive back up onto a box. So you're in ankle dorsiflexion, you're loaded, and now you're applying that force back again, just like you would in a real life situation, and particularly in basketball where that false step is such a common movement pattern. So you're loading the tendon in those ranges and teaching the neurologic rapid contraction that's needed, the body's neurologic response. Don't let that heel drop and hit the ground when you're in that position, because that's how you tear. And we saw that with Dante DiVincenzo this week, right? That's how you tear, is getting into that position. So
Nice, nice. So, um, I'm glad you brought up dorsiflexion because I do feel like we don't emphasize this enough. And when it comes to calf strain, like we are still doing plantar flexion test. So my following question is, how much value does seated plantar flexion or standing plantar flexion is going to provide us in terms of like dealing with potential calf strain or a return to play from calf strain?
I still am a big fan of having, a baseline value and having a strength value. I think that that's important. Um, Again, in football, soccer, these types of soft tissue injuries were much more predominant, although we are seeing more and more of them in the NBA. And I'm going to, very unpopular opinion, but I don't think practitioners in the NBA are very good at dealing with them, to be fair, as we see by the re-injury rates. And I think that, I don't know what it is going on behind the scenes. I don't know whether it's players with individual practitioners working with them, and different loading philosophies, or not loading heavy or not loading into those positions. I'm not sure, but I do think that there's clearly something there. And I think having a really good baseline data is so important. And to be honest, we're talking about the calf now, but we were able to identify either retrospectively or prospectively, but not intervene in time in our soccer players, by looking at various aspects of their data. And one of the things for hamstrings we found was rate of force development was actually a bigger, stronger signal than the peak force. And another thing that's really important is positional, looking at where the player is weak in terms of the position. So we tested our players for hamstrings in 3 positions in hip flexion, 30 degrees knee flexion, 45 and 90. And so we're getting positional data on the knee flexion range relative to the other side. And so when they do get hurt, we've got something to go back to. Same for the calf, right? We would look at a standing isometric test. It doesn't tell you everything because some players are nice and strong in a plantar flex position. You start to bring them down into neutral or a little bit of dorsiflexion, and then have them try and raise up, and they're so much weaker. So again, and you're also not just looking at strength; you're looking at endurance. So you're looking at how many heel rises can they do? Do you have, Seth or Neil talks about the tremor that you get in the bent knee positions. Do you have that tremor? That's a sign that you've either got some neurologic inhibition, weakness, both going on together. And all of those are important markers. I would say, again, professional women's soccer, but I would go so far as probably to say men as well as the NBA. Calf weakness is a epidemic. Nobody trains the calf, and I think that's something that's overlooked. I'm, old and slow now, but I can tell you that I was at the gym 2 hours ago and I still did my calf exercises. I'm still a big believer in that and trying to maintain some Achilles tendon health.
Nice, nice, nice. All right. So, uh, I'm glad you brought up hamstring because I was gonna ask like your thoughts on Norboard and force frame, because just from a personal experience, uh, the app either the athletes I train or my personal like experience, the more I do the force frame, the abductor squeeze, it helps in short term, but long term it actually make it worse.
Are you using it as a training tool or as an evaluation tool?
Uh, Probably testing, but at the same time, I'll do Copenhagen or adductor squeeze.
Yeah. So, you know, isometric versus through range for the adductor is different, and it activates muscle groups differently. I was on the PhD committee for a fellow who's working with the Washington Mystics right now, Derek Larkins, and he did his work on that. And I would have to go back and double check exactly his results, but effectively, in terms of adductor longus versus adductor brevis, and then if you bring in the rotational element as well, which I love to do with the Copenhagen, and bring in that rotational element because really that's part of what your adductors are doing also. You're achieving different things, but with an isometric versus a through range. With an isometric, you're also not getting again that soft tissue component, that elastic element of the soft tissue. So I think coming back to the original question about force frame testing, yes, we need to have a baseline value, and we do know that it's been shown in soccer players like that drops off prior to the onset of groin pain. Now, whether that groin pain is, adductor related, or whether it's pubic symphysis related, or whether it's hip related, that's a whole other kettle of fish. And Derek posted something about that this week actually, but it's really important still to have a baseline. You can produce more force at 45, and so we would expect to see higher values there, but I always like to evaluate zero as well. And then with the abductors and look at the add to abductor ratio, and of course see that shift. And my cutoff for those is zero point 0.9 to 1.2 as a ratio, and that'll give you a bit of a clue as to whether you've got somebody. You look at their overall adductor values, and maybe they're actually pretty good, but their ratio is off because their abductors are super strong, or maybe their adductors are pretty weak, but their abductors are also extremely weak. So their ratio looks okay, but they're actually still really weak, and they need to work on both things. So again, just relying on one metric doesn't tell you everything. You have to understand all of the different pieces that are going into this, and then train in different ways to get the different elements of the muscle groups, as we talked about with Derek's work. Now, go back to the Nord board. You must have heard me. I was consulting with a player who's over in the UK that's going to come and see us here in the States when our season ends. But hamstring injury, complex kind of injury with a 2B, 2C, and the bulk of the testing has been Nord board. It's a high biceps fem. So immediately there we're saying, we know that Nordics bias semi-T. Um, we know that they bias short-headed biceps fem. Um, and as the knee flexion component, and yet we have a high injury whereby there's a huge hip element to this. So, I don't not use Nordics as part of my rehab. I don't test Nordics. Um, in basketball players, especially bigs, uh, I think that their lever arms are very, very long, and I have actually seen meniscal stuff stirred up because of the shear at the tibiofemoral joint from the large lever arm applying excessively high forces. Semimembranosus attaches fascially into that posterior medial meniscus. And if you've already got some posterior meniscal pathology, which a lot of basketball players have, the chance that you could stir that up is there. So I don't need to mess with that. Guards are different. I think guards you can treat like a football player or soccer player, depending on their size and their weight, but I'm talking your smaller guys. But I think that, again, I told you we do this three position test that came out of a guy by the name of Prosky, who was an Australian researcher. I think he's probably since passed because Yui was quite old when I first met him in Australia. But I think their papers were the late 90s, and they looked at weak outer range, so in that 30-degree knee flexion, 90-degree hip flexion, as being a predictor of hamstring injury. When I was at the Sixers, we would look at that, and then we would also do a torque calculation by measuring the length of the tibia, and calculate torque in the three positions, and we'd look at the torque curve. And what I was looking to see is, do I have a torque curve that kind of does this, which is what I'd expect, or do I have a torque curve that does this, and then that 30-degree position drops off the map? That's a concern to me. And again, we're able to identify preseason one of our athletes, and he ended up with a grade 1 strain, but we actually modified his preseason, added a whole bunch of hamstring work, and I would argue that it would have been a hell of a lot worse had we not identified him and then been able to intervene. And so, uh, you know, I think again we've thrown the baby out with the bathwater in terms of, oh, that's old research. Everyone says, oh, I need to see references from the last 5 years. Well, there's some really damn good research from the 80s and 90s, and especially in this area. And guys like James Moore, my friend and colleague, who is even far better at the muscle stuff than me, but he will tell you, a lot of references in his lectures are from the 80s and 90s. And I think that going back and looking at that. We know that Nordboard testing, it's not a predictor of hamstring injury. We're identifying, patterns there, and I don't think there's anything wrong with using it in certain populations. I know, again, it's used a lot in football, but um, I actually really liked our test better. I think we were able to really evaluate rate of force development in that position unilaterally, three positions, understand where the deficiency was, and then really target the training.
Is it a seated knee flexion position or
Yes, it's a seated position in knee flexion. We actually used the dynamo. We rigged up the dynamo. We strapped the players down at the waist. I actually went down to Vauld in Brisbane when I was back home on one of my trips back to Australia, and we worked on this testing position together at the Vauld lab there in Newstead in Brisbane, and so came up with this kind of protocol with the dynamo.
nice, nice. All right. Another question related to this is like it's also like somehow my personal experience when I deal with athlete, I feel like a lot of hamstring strain, not a lot, but yeah, a lot of hamstring strain I deal with, or a lot of like adductor strain or groin strain I deal with. If I look at their pelvis or lumbar-pelvic region or like their SI joint, usually it's the pelvis out not aligned or like the SI joint somehow is stuck. I do think like this is a coincidence or like maybe we could look more into that.
Well, you're getting a bit of like Jordan Mendegucci's work here, hamstring expert out of Spain, and a friend of mine has done some great work in this space, looking at anterior pelvic tilt and whether you can change that, and showing that you kind of can. And you know, when you're addressing um, or you're referring to pelvic asymmetries, we talk about it all the time, and we talk about checking our players' hips and pelvis, right? I think it's important, the verbiage we use, players can connect with and understand, but there's also an anatomic understanding of exactly the fact that you've got very little motion at that SI joint, especially in a healthy SI joint that doesn't have an instability for some reason, or a sprain or joint erosion or anything like that, right? So you're dealing with very, very small degrees. So you're not really seeing an anterior anomaly or a posterior anomaly. What you're seeing is patterns of muscle spasm. And those patterns of muscle spasm are pretty consistent. I go back to Mark Comerford's work way back from the 90s and early 2000s that I really prescribed to early in my career, and that shaped how I think about the pelvis. And man, my whole career, that stuff has held pretty true. Um, you know, and so I'm really looking for these patterns. And then, obviously I'm looking at, hip flexor length as well, and control in terminal hip extension, and the ability to control that lower abs and maintain posterior pelvic tilt. Usually you're looking at the opposite side with that as much as you are anything, as well, because as that leg is, in terminal swing phase, your other leg is, oh, sorry, is in terminal recovery phase, and you're coming back through your other legs in terminal swing, and that's where your tear occurs. So if you're tight on the opposite side, then you're putting yourself in a predisposed position. So, not just looking at the symptomatic side. I also am a very centrally based practitioner, so I really, believe a lot in the neural element and the neural component to this. I don't think I've ever treated a hamstring without treating the thoracic spine, the lumbar spine, the pelvis, and the whole thing. Same applies to the calf. When you look at these hamstring injuries, and particularly the one that I just described, these proximal, 2B, 2C type injuries on ultrasound, and I track these over time, but the sciatic nerve is right there, right next to that muscular tendinous junction. And of course, there's inflammation and scar tissue building up around there. So you need to be maintaining mobility through that neural element. And I think that's an element of some of these re-injuries as well. Um, there's people like Professor Childers over in the UK that would talk about denervation, and an element of tearing actually some of the innervation into that muscle that never recovers, and denervation from the tear. So these neural elements are super important, and you can change range of motion. You talked about baseballers. One of the easiest things to change internal rotation, in a GERD situation, is to mobilize their C5-6, particularly an AP mob, and you'll see this thing just go from here to like here, and you didn't touch their posterior cuff. Of course, the tissue's already traumatized from throwing, so I don't have to beat it up. And that was a trick I used back in the day at Georgetown with our baseball players all the time. And the same thing happens in the lumbar spine and pelvis. You can change hamstring tone and range of motion by working through there. The thoracic spine, the autonomic elements of the lower thoracic trunks autonomically as well over the costovertebral joints. I do a lot of work through there. So to your point, yes, absolutely. I think if you're not doing that, then you're doing your athlete a huge disservice.
Nice. All right, last question. Also kind of related to this. There's different expert talking about like at least tendon, and well, actually it's the same. So uh they're saying like part of the reason that like the Achilles tendon been taking so much load is because they somehow lack hip internal rotation. So your body need to find extra internal rotation. By doing that, need do excessive pronation. So the Achilles tendon take up more load. Am I making sense or am I talking crazy?
Are you talking about, yeah, potentially in more chronic Achilles situations, less necessarily from the acute rupture type situation?
Nice, nice. So if it's a chronic tendon load, like looking at hip still makes sense.
I think it does. I don't think. that's where your biggest bang for your buck is. I think your biggest bang for your buck is really looking at what's happening from kind of the tibiofemoral joint, tib-fib joint proximally, looking down at the subtalar joint, your mid-tarsal joints, your MTP1, and the ability of the foot. Like, so let's take a classic, what I would call a classic basketball foot. Inverted hind foot, pronated midfoot, no MTP1 dorsiflexion, right? We see that it's a dime a dozen every day in the training room in the professional basketball. Um, and if you put the foot in that position, we know the different elements of the Achilles attaching um, pertain to different parts of the muscle structure. So medialis attaching slightly laterally, lateralis slightly medial, so soleus attaching on the ventral side and kind of central to medial side of the calcaneus. If you put it in one position, you're just going to keep chronically loading that. And then you come back to Carlos Pedritz's work and you start to look at what he looked at with morphology predisposing to calf muscle injuries. And he was like, oh, some people, from the central tenon of their soleus, they've got no medial soleus and they're all lateral soleus. Some people have no lateral soleus and they're all medial soleus. And I've seen that a lot in football, right? And so then they start really overusing the medial side. The medial fascia gets very thickened. The plantaris tendon then gets very thickened. And, the foot gets stuck because they're really cranking on all of the medial fascial system. So part of then, restoring foot mobility and normal foot function and then training the calf muscle, but making sure you're getting the lateral and the medial elements. And I do that by wedging the foot, putting it in different positions. All of those things I think are really important pieces of the puzzle, probably more than just looking at the hip. To be fair, foot external rotation was a feature of Achilles tendon rupture in NBA basketball players. The external rotated and triple extension position was a feature, and that's been reported in other studies. That does wind up the Achilles tendon a little bit more. Is that a function of not having hip extension and hip internal rotation? Maybe. And maybe there is something to be considered there as part of the biomechanical chain. What I would say is if you want to do that as well, I think that's great. If you're doing that instead of, then you're missing the boat and you're being too cute, as I say. And I think we can be too cute. There's no question that having no MTP1 dorsiflexion changes things up the chain and could affect your hip and your pelvis and what have you. But if we're starting at the MTP1 and not really addressing the area that's problematic, then maybe we're missing the boat. Maybe we need to be, doing both, if anything, but definitely not missing the big rocks. And the big rocks are how that foot, ankle, and calf muscle functions, and then knock yourself out on the other stuff. I think it's important to look at, but a lot of people make their living by being so nuanced. Oh, I'm doing this thing, no one else would look at this. But then they miss the big rocks, and I think that's a mistake.
Nice, nice. That's all the question I have for you today. Before I let go, I do want to let you know that, like I said before, Adam always say like you're one of the smartest person he know, and every time I talk to you, I feel like I learn a lot. So I appreciate that.
Thank you for that, Eric. You're always very complimentary. Make sure my wife listens to this and agrees. Hey.
All right.